So I already said that there is a big awareness for us sport doctors to have the opportunity of the treaty of the guidelines on intra-articular treatments of Italian Sport Medicine Federation. This is a work in progress because we had a wonderful achievement with the consensus, but with Alberto as is writing the final results of the work which began many years ago. 2014, the first idea to involve Alberto Migliore in this path. So the Italian Sport Medicine Federation is a sport federation recognized by Italian Olympic Committee. This is the audience that welcomed over 3,000 participants coming from all 5 continents, representing the 117 International Sport Medicine Federation member countries, last March 2019 in Rome. According to the statute of the Italian Sport Medicine Federation, it has the function to ensure the protection of the health of athletes, also to guarantee the regular and correct conduct of the competition and the championship of every order and degree. In Italy, there are 5,000 sport doctors. We take care of the health of the athletes during important competitions, such as Olympic Games. And bodybuilder of agonistic level, this is the competitive athletes who come to our surgery, and we have to take care of them. An important role of sport medicine is training in the field of cardiology. I told my colleague of Spain 50 minutes ago, traumatology, dietology, pneumology, muscular ecography, infiltrative therapy with echographic guide. And we have a gap. We have a gap, and we have to fill it up to this gap, according to Alberto Migliore. The aim of our work has been to identify pharmaceutical drugs and medical devices that can be used in filtered therapy of athletes and the safety profile, and the legal medical aspect in accordance with the laws of WADA. WADA is a World Anti-Doping Agency. Remember, next year is a particular important for us for Tokyo Olympic Committee. And then the organizational aspects of intra-articular injection and use of the echography. This is the steering committee represented by Casasco Pigozzi. Casasco Maurizio is the president of Italian and European Sport Medicine Federation. Pigozzi is the president of the World International Sport Medicine Federation. And other people, and obviously Alberto Migliore is the most important selected by us. This is the reference for every one of us. And this is the scientific board for the consensus about one expert of intra-articular injection for every region. So this is a committee of about 30 experts from every region of Italy, universities, public hospitals, regional committees of sport medicine, public services of medicine or sport, club doctors of Liga E or soccer teams, all experts of intra-articular therapy with ultrasound guide. The Commission has examined the documentation prepared by the steering committee and the verification and discussion of the question and recommendation. This is the protocol. And we have obtained a large consensus on the questions put to the participants on the scientific board. This is the research questions. What type of hyaluronic acid? EV, light, molecular weight concentration, volume per joint, viscosupplementation before or after the athlete's competition, cortisone usage, PFP, collagen, ozone, and usage in infiltrative medicine, regenerative therapy in sport medicine, recovery time after injection. Where is the injection performed in a sterility condition? Should the ultrasound guide be used or not? What clinical evaluation are considered before injection? Was pain, range of movement, functional exams, imaging articular dysfunction, laboratory exams, and intra-articular therapy in minors. This is very important for us because we had the trade union between the clinical use of the medical devices and the sport. This is such any criteria included by the librarian suggested by the steering committee, athletes, intra-articular, partendinous, intratendinous, injection. This is all the sport were included in the research in the PubMed line. It is the flow chart obtained by the suggestions of the steering committee through the librarian. We have selected 12 articles, included the suggestion put on the table of discussion. Tendinopathia, articular treatment, PFP, ironic cases, the sound guide, in a different presence in the article, in the 12 article selected. MRI, ultrasound, undefined imaging, RX, and so on. And these are some papers about the literature selected by the librarian. So let's go to this discussion and to verify the consensus of the arguments selected. Discussion, the question with the complete board. When we involved all scientific board to give us the answers on 3 possibilities. I do not agree, agreement with reservation, and I agree. And then on the basis of the replies, we are going to write the final paper on the recommendation. So let's go the first suggestion. What type of hyaluronic acid, EV, light, molecular weight, concentration, volume per joint? How to choose the most suitable HA in the intra-articular therapy on the athletes? How much hyaluronic acid, volume per articulation? So there is no literature data at the moment or sufficient data that allows us to respond to the question. There are only 2 studies that show the use of hyaluronic acid in the joints of athletes. 2017, Papalia studied the hybrid hyaluronic acid product versus PRP in 48 professional football players, highlighting the superiority of HA. And another article described the use of hyaluronic acid in the metatarsophalange of the golfer. And then there are many studies about per-articular hyaluronic acid, the term proposed by Alberto Migliore. The choice of HA awaiting an increase in EBM can be at the moment based on the biological, physical, and rheological characteristics of hyaluronic acid products currently in the market, or on the basis of the shock-absorbing viscoelasticity and residence time capacity within the joint. In the absence of EBM and clear literature data, HA, low, medium, high molecular weight products, cross-linked or mobile reticulum can be used in agonistic and non-agonistic athletes. You know that the consensus was 9 against 6 agreement with reservation, and 2 I don't agree. What are the volumes of hyaluronic acid to be used in athletes' intra-articular therapy? With regards to the volumes of HA to be injected into the joint of the athletes, recommend following the instruction which come with the package of each individual product. For the knee and hip, we have a precise literature data only for patients with arthritis and not specifically agonistic or non-agonistic athletes. For the other joints, we can make suggestions on the basis of the small amount of data available and on the basis of clinical experience, such as for the hip, you can inject 2-4 milliliter up to 6 milliliter. For the shoulder and the ankle injection, 2 milliliter volume is considered appropriate, while for the small joints, the injection must be carried out under echographic height. The recommended volume is from 0.3, 0.7 milliliter according to the capacity of the articulation. What are the volumes of HA to be used in the athletes' intra-articular therapy? So I agree, the large consensus on the theme treated in the last slides. Is it more advantageous doing a repeated injection or one shot in athletes? A smaller number of injections together with a greater biomechanical capacity of the product may generally be better in the treatment of musculoskeletal pathology of the athlete. There is no existing literature data on this. The reduction at the number of infiltration involves the reduction, obviously, of the risk of infection, especially in patients with comorbidity. So is it more advantageous doing a repeat injection of one? Is obviously that large consensus on doing one shot. Cortisone usage and what type, volume per joint, before or after competition. It is recommended to choose a corticosteroid that presents a less systemic absorption to avoid its detection in the serum. During the competition, the drug must not be present in the blood. And which the best intra-articular corticosteroid for the athlete? From the clinical use data on osteoarthritis, according to EBM, the triamcinolone acetonide shows great evidence of rapidity of action on pain. In vitro, low doses of desamethasone increase the synthesis of proteoglycans in cartilage and inhibit their rupture after compressive damage, both in presence and absence of inflammatory cytokines. Other laboratory data and clinical experience suggest that a single dose desamethasone injected immediately after an injury may prevent the development of post-traumatic osteoarthritis. There is a paper published by Evans and Godinsky in 2018 about the effect of short-term glucocorticoid treatment on change in cartilage matrix degradation induced by mechanical injury and inflammatory cytokines. There are different products of corticosteroid for intra-articular use: triamcinolone acetonide, methylprednisolone acetate, hydrocortisone. There are only 3 studies of intra-articular use of steroids in sports, but none of them explore the comparison between different products. On the other hand, we have data in the case of symptomatic osteoarthritis in the adult showing different effectiveness and length of stay within the joint. This data may also be exported for clinical use in the athlete. So this is important, our comparison from clinical use and use in the athletes. So which is the best intra-articular corticosteroid in the athlete? So we told about the triamcinolone acetonide, and a large consensus is on the use of triamcinolone. What is the best corticosteroid dosage to be used intra-articularly in the athlete? As in osteoarthritis, it is recommended to inject the volume and the dosage indicated in the instructions. If more joint has infiltrated, it is advisable not to exceed the maximum dose foreseen for a single injection. In athletes, there is no evidence in literature regarding to the volumes to be injected in the intra-articular therapy with corticosteroids. However, an overdose of intra-articular cortisone must be avoided because there is still a systemic absorption through the synovium of the joint. For example, in the case of the administration of triamcinolone acetonide, it is advisable not to exceed a total of 40 milligrams, even if more joints are injected. So, the best corticosteroid, we recommend to inject the volume and dosage indicated in the package insert, the large consensus to this question. We must remember that in the World Anti-Doping Agency list of prohibited substances, all corticosteroids are prohibited for oral, intravenous, intramuscular, and rectal use. Find them in the serum or urine results in an illicit act. The list of World Anti-Doping Agency substances prohibited is maintained by WADA and published every year in English and French. We can download from internet very easy, because we have to remember that athletes are responsible for any prohibited substances or its metabolites or markers found to be present in their samples. PAP, type, volume, joint, before or after competition. What type of platelet-rich plasma is most useful to use in intra-articular, intra- and peritendinal therapy of the athlete? There is no data in the literature supporting the use of one PAP over another. There are different types of preparation for the PAP and its activation. Pure PAP, PAP-rich in leukocytes, pure PAP-rich in fibrin, PAP-rich in leukocytes and fibrin. PAP is not amongst the list of prohibited substances, despite the presence of some growth factors. The epiastrinic derivation preparation have been removed from the list of prohibited substances, as the recent studies on PAP do not show any improvement in performance, so we can use. For example, growth hormone releasing hormone, and analogous insulin-like growth factors, corticotropins, and a number of other growth factors are all prohibited. What type of PAP is most useful? There is no data in the literature supporting the use of one PAP over another, so large consensus on this question. Collagen and ozone in infiltrative therapy. The use of intra and perarticular collagen acts differently from the HA and may be used as an alternative or associated with it. There is no data in the literature regarding the use of intra and periarticular collagen in athletes. However, patients with knee osteoarthritis in double-blind randomized study were treated with 5 intra-articular medical devices or EJ infiltration in the knee. This is a work published by Alberto Migliore. Both groups showed a reduction in pain and an improvement in joint function. So the rationale behind the use of intra and periarticular collagen is dictated by its role of mechanical support to the articulation. Moreover, its degradation in essential amino acid may provide a nutritional support to articular tissues. The use of intra and periarticular collagen acts differently from the AJ and may be used as an alternative or associated with hyaluronic acid. I agree, 9 point, agreement with reservation 6. The aid of ozone in infiltrative therapy of athletes. Subcutaneous, intramuscular, and intraarticular injection of an oxygen ozone mixture are used for the treatment of different sport pathologies. There is no sufficient data at the moment in the literature of the validity of therapy, but the treatment is permitted by VADA intraarticular injection, via intraarticular injection, but not through the blood. So it's not prohibited if we use ozone therapy into the articulation, but not through the blood. I agree, large consensus. Regenerative therapy in sport medicine. The option of regenerative cell therapy in athletes. Currently, World Anti-Doping Agency guidelines prohibit the use of cellular concentrates in athletes. In the literature, there are no papers on the use of mesenchymal stem cells in intraarticular therapy of the athlete. Mesenchymal stem cells can have low or high manipulation at the moment. There is no accordance between the different way of preparing the mesenchymal cells. And mesenchymal stem cells can be extracted from the umbilical cord, from the bone marrow, from the adipose tissue, synovial, and peripheral blood, you know. And there is not still certain data on the optimal concentration per milliliter of cells to be injected. A clinical experience in arthritis seems to highlight that the early injuries and health are positive predictive factors for a better outcome in treated patients. This is a broadening horizon for us as sport doctors from the clinical use. According to the VADA, the use of cellular concentrates and stem cell is not permitted in the athletes. So everybody's 13 point, I agree, 3 experts were at favor of a clinical use of mesenchymal cells. When can sport activity be taken after an infiltration? The recovery of physical and sport activity is possible after the complete resolution of painful symptoms and the integral recovery of specific sport athletic movement. We know that the athlete is not a normal patient, and when we follow the athlete during a competition, we are obliged by the president to let the people come to the competition as soon as possible. But the recovery had to be as possible after the complete restoration and the clinical experience acquired on athletes of various agonistic disciplines and levels suggests that if the treated joint, whichever it may be, or the treated anatomo-functional district do not present any pain or functional problems, then the resumption of sport can be allowed, both for training and competition. When it's possible, no, agreement with reservation 7, and I agree 10. What precautions are important in the execution of interarticular therapy in order to guarantee an ascetic approach? Interarticular therapy in athletes, as in other patients, must only be carried out in hospitals, clinics, private surgeries. But you know that when we follow the athletes, we found in hotels, and we can be in not so 100% hygienic conditions. The dressing room is not suitable for those environments which do not meet the minimum hygiene sanitary requirements. Interarticular therapy is always an invasive therapy and must only be carried out by doctors to guarantee the facilities necessary for assistance in the event of an allergic reaction, vagal crisis, or other emergency. Accurate skin disinfection is required, and the area of skin where the injection is performed must be free from any kind of lesion. The operator must wear sterile gloves. Simple suggestion, you can say, is obviously, but is not clear for every doctor. Provide sterile covers for ultrasonography probes and use sterile echographic gel. So the total consensus on the sterile condition to be followed during an injection. When is it useful? When is it essential to use the echographic guide? It is also highly recommended to use ultrasound guidance in all joints to be sure of proper entry and interarticular distribution of the products. The advantage of ultrasound are an excellent resolution for soft tissue, infiltration accuracy, low cost, easy access, the absence of ionizing radiation, and the ability to perform real-time image. The accuracy of the technique based on anatomical landmarks is suboptimal with respect to the ultrasound guide technique. Clinical and cadaver studies have shown that ultrasound-guided interarticular injection is more accurate than the performed with anatomical reference landmarks in the fully wound joints, every joint. And we meet already doctors who insist doing injection without ultrasound guidance. The echo-guided procedures were particularly advantageous in obese patients in the case of arthrocentis, but in every people, in every heart, must be carried out under ultrasound guidance. For this reason, it is recommended, highly recommended, that echographic guide is used as a routine procedure for interarticular and periarticular infiltration. When it's useful, so the reason we talked in the 2 or 3 slides before, large consensus. When is it useful to carry out a diagnostic examination before infiltration? When we follow a team, it's not normal, so easy find MRI or CT to perform an exam before doing an injection. So when it's possible, it is convenient for us. Before carrying out an interarticular therapy, an appropriate examination, diagnostic imaging is recommended. The echographic examination allows us to study the muscular and tendon lesion in real time. We know the low cost, the favorable cost-benefit ratio makes the ultrasound for us sport doctor the gold standard for the assessment of tendon muscle and interarticular lesion for the subsequent follow-up. So, large consensus. What clinical laboratory parameters are useful to assess before deciding on viscosupplementation? In addition to collection of anamnestic data is important, and instrumental and functional assessment of the joint, it is necessary to exclude other systemic factors that could alter the result of viscosupplementation, as in the clinic normally. There is no difference between sport athletes and normal patients. In particular, hematology, diathesis, and chronic inflammatory diseases should be excluded. It is useful to perform a laboratory test such as blood count, glycemia, prothrombin test, to exclude the presence of relative or absolute contraindication through intra-articular therapy. Synovial liquid analysis should be carried out in the context of the differential diagnosis between post-traumatic effusion and secondary effusion of an inflammatory disease. So I agree, 70 people. Other predictive factors of the result of viscosupplementation. There are no studies that investigate the predictors of viscosupplementation response in athletes. However, the predictive response factors reported in the clinical use of viscosupplementation in established knee osteoarthritis could be considered. So a large consensus on this question. Is it possible to combine hyaluronic acid and corticosteroid? What are the indications associated or sequential use of cortisone and hyaluronic acid is possible, especially in cases where quick relief of pain or control of local inflammation is needed. The rationale behind the association of the two products is to exploit the combined effectiveness on the pain of the rapid action steroid and the prolonged effect of HA for a quick and length recovery. Is it possible? A large consensus, 15 people. Intra-articular therapy in minors, indications and precautions. Last question. The presence of cartilage in fertile growth recommends to execution of intra-articular administration and imaging guides. Is obligatory, is mandatory. The echographic guide should be preferred to radioscopy due to absence of radiation, obviously. Corticosteroid therapy we use in the children is to be considered as an aid in the management of sport rheumatology because the main therapy is constituted by gradual rehabilitation. But we use the combination of hyaluronic acid and cortisone in the children too. And this is a point to be, which have to be discussed very deeply in the treaty of guidelines by our society. So the present cartilage in fertile growth recommends the execution and articular administration of the imaging guides and should be preferred to radioscopy due to absence. 9 people against 7 in agreement with the reservation. So that's all, and we wait for the final paper.